good. So welcome to the afternoon session on medical assistance in dying. This is a really big topic. This is a very new thing for all of us to be thinking about. And I thought that the committee thought that this would make a very good keynote really subject for the meeting. So we have set aside an hour for this talk, and we're going to hear from many members of our panel that we've assembled here this afternoon. I'll introduce them in a minute, but just a framework to how the session's going to flow is we're going to have a couple of formal presentations, we're going to have some case-based discussions, and then we've set aside a lot of time at the end of this for discussion. So something that we've been hearing over the lunch that because of timelines, we didn't get so much discussion as we'd like. This is our meeting. We want to hear from you. This is a really big topic. We know there's anxieties about this. We know that we all want to develop a comfort level in dealing with medical assistance in dying. And I think this is a forum to ask questions. So our apologies that I know there were questions that were forwarded in the app, so we didn't make a formal discussion about that, but people had figured that out. Please keep those questions coming. We welcome, there's microphones again throughout the room. We've got 2 people who are going to carry around a microphone as well if you prefer a more personal interaction. Whatever venue you'd like, just please keep those questions coming, and we will certainly have time to address the questions off the app and use them as a launching point for our discussion. So the first person that I would like to introduce then is Dr. Mohamud Karim. We all know Dr. Karim, and we're going to get to know him a little bit later today as well at the Wilma Crockett Awards. I think he's prepared a couple of cases to first discuss and frame this issue, and I'll welcome him presently.
Thank you, Caroline. It's a pleasure to be here this afternoon. The theme for today, patient transitions and perhaps end of life and palliation, as perhaps being the single most important transition that our patients and also we will need to make in life, one that is sort of ethically and emotionally charged and challenged, and they seem to be shifting boundaries and norms, and we find ourselves back again in nephrology in these shifting boundaries and norms. Nephrology is no stranger to these shifting boundaries and norms of ethics and ethical challenges and where we go from the early days of who would get onto dialysis and who wouldn't, and then an era where we expanded dialysis to everyone, and then perhaps a swinging of the pendulum back to offering conservative care and withdrawal of dialysis as part of our culture and part of our language. But we seem to be now yet at another boundary. In all these previous eras, however, it seemed to be that the medical profession was in the driver's seat from which policy and legislation followed. And somehow it seems like that has been reversed, and we now, society and the lawmakers have taken a certain stance, and it is us as care providers now to see how we fit into that and how we accommodate to a new reality, to assist in dying, and then reduce it to an acronym, MADE, and that also says a lot. So we'll see what we need to chat about that. I'm going to share some cases that demonstrate the challenges and some of the questions, and to contextualize the discussions later on. The first is of an 89-year-old gentleman that I saw about 6 years ago, referred by cardiology for renal dysfunction and a GFR of 31. And as is usual, he had a previous bypass graft, he had a history of hypertension, valvular disease, and he was slotted into our CKD clinics for follow-up. Over 2 years, his GFR continues to drop, he's counseled, he wants dialysis, he's referred for an access, the surgeon declines it, saying it's too high risk and he may never need access. The course continues. He's staying in assisted living with his friend who's a widow in her 80s who lost her husband to dialysis. He's admitted with volume overload and a GFR of 13. And so he's offered the traditional choices. Do you want dialysis? Is this something that you'd rather not have? And can nature take its course? What if he had requested MAID? Where do we go now? How do we counsel him? Does MAID become yet another option that is offered? And if we do offer it, who offers, who counsels, where does this belong in the overall spectrum of choices? And how do conscientious objections play themselves out? Is it the cardiologist? Is it us? Is it palliative care? Is it the hospitalists who are looking after him? As an aside, Mr. K actually started dialysis, was fine for 6 years, and then passed away after getting increasingly ill, frail, and eventually stopped dialysis. The second case Mrs. S referred again for decreased GFR of 32, a prior history again of a bypass graft, diabetes, and hypertension. She's continued to follow up. Her GFR drops, now 19. She has increasing pain from severe inoperable osteoarthritis, getting slowly bedbound. She has ongoing pain. Her GFR drops a year later. The family is still keen to pursue dialysis, and mom goes along. She is admitted not well on hydromorphone for pain. The family is counseled on the burden versus the benefits of dialysis, perhaps with the recommendation that she be managed conservatively. The family, however, is still keen on trying dialysis. She has mentioned that life is unbearable and sometimes wish she could end it. For her, life on dialysis would be untenable. So do we mention MAID as an out, or will this open up a Pandora's box that we don't really want to deal with? And again, what are our options? Conservative, palliate, and dialysis? Or do we now add another option? And is silence on this now acceptable when we are looking after patients and simply wait for them to bring it up? Case 3, a 19-year-old who has aggressive IgA nephropathy, aggressive on dialysis within a year after presentation. 2 years later, he has a live donor transplant from his mom. And this again is complicated early on by recurrent IgA in his graft. It's felt to be aggressive enough to warrant immunosuppressive therapy with high-dose steroids and cyclophosphamide to salvage the kidney. He's back on PD 3 years after transplant, complicated by underdialysis, pericarditis, a parathyroidectomy, and then returns back to hemodialysis. A lot of his problems were thought to be due to non-adherence to treatment. He has severe hyperphosphatemia, hyperparathyroidism, and bone fractures, femoral neck fractures, and severe unremitting pain. He declines investigations, declines more aggressive dialysis, and starts to inquire about stopping dialysis. He's provided information on what to expect if he stops, 1 week on average, and then palliate either at home or in a hospital or in a hospice. He has ongoing inadequate hemodialysis and is given morphine for pain. He eventually pulls out his hemodialysis catheter, and after much discussion and consideration given to competency, depression, the team felt he was making an informed decision and was then stopped dialysis, supported, and admitted via palliative care for end-of-life care. Now here again, in stopping dialysis, we're usually dealing with less than a week, and we've not yet been asked about stopping dialysis and medical assistance in dying shortly thereafter. Is this a question of time, where we will be asked about whether we can also administer medication to assist dying in addition to stopping dialysis? So personally, so far, I've had no moral discomfort or unease in counseling patients about conservative treatment or discontinuing dialysis and let nature take its course, especially when dialysis prolongs the process of dying rather than life. However, I'm simply not able to cross the boundary and take an active role in becoming a MAID doctor. I don't quite know how, what I would do, and under these circumstances, would I now no longer advocate for stopping dialysis, knowing that it will then lead to some of us being placed in a morally difficult circumstance. This then is hopefully what the panel will address today.
I think just to ease the subsequent transitions, what I'll do is introduce the rest of our panel all at once, and then I think things can just flow. So I'd like to next introduce Dr. Heidi Otter. She's, I don't know if I should say this or not, but I will. She's my former neighbor. We grew up on the same street. So we went down a bit of memory lane before this meeting. Dr. Otter worked for 18 years as a family physician in this province before working with the College of Physicians and Surgeons of BC, and she's currently the registrar, so she's very nicely positioned to be able to speak to us about her two objectives, the ethical and professional obligation of physicians regarding MAID, and to understand the role of MAID in end-of-life care. Next, we'll hear from Dr. Barwich. Dr. Barwich is a palliative care specialist. She's executive director for BC Centre for Palliative Care, and prior to this was Canadian Society for Palliative Care Physicians head. So comes at this from a different perspective, but carries indeed a lot of experience. So we're also very grateful to have your presence here today. Dr. Bashir, next is Peter Shervin. Excuse me, Peter. Peter is my co-worker at Royal Jubilee Hospital, and those of us from the island will recognize Peter. He's worked with our patients for 23 years, so he's really a fixture at the hospital. A lot of our chronic patients know and very much rely on Peter's wisdom and old Bibles and expertise in care and compassion, so he will bring, again, a unique experience to this discussion. And Dr. Bashir Jawani, who's an ethicist at Fraser Health, to round out our panel. So perhaps we can have one round of applause for everybody, and then we'll just transition them through their portion.